Good afternoon, everyone. I will be presenting on direct ophthalmoscopy, a window to the fundus. Ever wonder why we cannot see the retina with our naked eyes? Yes, retina is very reflective. Only one ray out of 10,000 to 1 lakh are reflected back. So we need a bright light to see the fundus. Funduscopy is the procedure to view the back of the eye, also known as the fundus. It can be done by direct ophthalmoscope, indirect ophthalmoscope, or slit lamp biomicroscopy with 90D lens. A bit of historical aspect, ophthalmoscopy was invented by Babbage. However, its significance was not recognized until von Helmholtz reinvented it in 1850. Coming to the parts, we have on the patient side, we have a mirror, aperture and filter selector. On the doctor's side, we have a doctor's eye window, a lens wheel, a lens indicator. We have a brow rest, a lens wheel to change the diopter, rheostat on and off, and a thumb rest. Coming to now the principle of ophthalmoscopy, if the patient is emmetropic, light rays are directed from a light source in the fundus are reflected as parallel beam. This parallel beam enters the pupil of an emmetropic observer. The rays are focused on the retina and an image of the fundus is formed. Image is virtual and erect and magnified by 15 times. Direct ophthalmoscopy, main thing is the optics of direct ophthalmoscopy. Considering we have an emmetropic patient and an observer, we have a light bulb, two convex lenses and a 45-degree angled mirror with a slit in between it. Light falls on this mirror and is reflected on the patient's retina, which the observer sees. We have an aperture in between which can be changed. We have a small, large, a cobalt blue filter or a red free filter and a fixation target. There is a convex or concave lens wheel which can be changed to emmetropize the eye. Equipments and patient preparation, mainly we need a dark and dimly light room, a mydriatic eye drop. Patient positioning is very important. Seat facing the patient at the eye level, ask the patient to fixate at a distance object. At an arm's length, we start examining, we follow the red reflex, and we generally we do it if we are examining the right eye of the patient, we use the right eye with and we keep our left hand to fixate ourselves. Now, what to look for? First of all, we look for red reflex on distant direct ophthalmoscopy, any opacity in the media. Adjust the focus and examine the vessels, locate the optic disc and find the macula. There is a concept of parallactic displacement where if the opacity is behind the pupillary plane, it will move opposite to the movement of the observer. If it's in front, it will move with the movement of the examiner. As a beginner, we are taught like we have to find a vessel, we focus it, trace it nasally to find the optic disc, and 2 disc diopter from it we have the macula to see the fundus. Advantages are highly magnified detailed view of the central retina, portable, inexpensive and readily available, easier to use with undilated pupil, narrow field of view making peripheral retina examination difficult, lacks stereoscopic or 3D vision, difficult to perform through pupil, small with media opacities, and examination is time limited due to patient discomfort. Next generation newer advancement is Welsh aligned panoptic plus ophthalmoscope, which has a 20x larger viewing area, quick eye trademark alignment technology, and digital image capture, which helps in patient comfort. Easy, high magnification and high illumination is better with this type of ophthalmoscope. Thank you.
Thank you so much, and even I learned a lot about new things about direct ophthalmoscopy today.
I want to ask you a question as a student. What causes magnification?
It mainly depends upon the power of the eye. If it's high, if the power, in case of myopes, if the power is converging power is high, so magnification will be more.
So you said 15x, no? So it will more in myopes.
In myopes, it will be more, and in
astigmatics, will there be anything?
In myopes, it will be more. The field of view will be less.
Patient has astigmatism.
We have lens wheel to change the diopter of the, to emmetropize the eye, to change the diopter.
What is Rako's disc?
Yes.
Rako's disc.
Yes.
Lens wheel is called Rako's disc.
Why can we not see a red reflex with a torch and see it with the direct ophthalmoscope?
Actually, we need a pinhole to see it. We can also see it through a glass mirror with a pinhole in between it. because all of the rays are not reflected back. Few rays are reflected back, so we need a pinhole to see through it.
So what is coaxial illumination?
Okay, next class.
Are the structures in the pupillary plane, they move with or against when you are doing the
Pupillary plane, they will be stationary. They will
nodal
seem
point or
station-
pupillary plane?
Pupillary planes.
I think it's a nodal point, you know. Any structure in front of the nodal point of eye, which is just in front of the posterior surface of the lens, they move with, and others behind the nodal point move against
Against.
when you're doing distant direct observation.